So, when we talk about aortic pathology, I just want to briefly discuss sort of operating on anything to do with the aorta on an aortic vessel, okay? So obviously, when we operate in the aorta, its unique challenges is that in vascular surgery, typically we have to enter the abdominal cavity. Unlike when you're operating in the periphery or the legs, we don't enter the abdominal cavity. So whenever we enter the abdominal cavity, treat it like abdominal surgery like you would in any general surgery in terms of preparation. Vis-a-vis simple things like the preoperative clearance. 100% of people, in terms of a preoperative standpoint, all patients have to have some sort of cardiac clearance prior to surgery unless it's an emergency, okay? Now we are planning to at some point, whether it's 6 months, 1 year down the line, they start to do sort of emergency aortic cases, but not in the interim. There's a lot of groundwork that goes into it, as you all know, in terms of like staffing, getting the appropriate sort of first assistants and scrub techs to be part of a team to assist us in doing these cases. So briefly, just talk about from a preoperative standpoint, what the things that you guys have to watch out for is you've got to make sure everybody has the appropriate preoperative cardiac clearance. Usually the staff gets everybody to go to a cardiologist, get clearance, and then come for surgery. They come and see us back, and then they go for surgery. All people for preoperative clearance have to stop the dual antiplatelets and their anticoagulants. No questions asked. That's one case where we cannot allow a patient to be operated on if they're on dual antiplatelets, unless it's an emergency, of course. So any elective case, if somebody is on Plavix, Efficient, one of those other antiplatelet agents, Coumadin, whatever else it may be, the case gets canceled, right? Even if the patient has taken even 1 dose or 2 doses in the prior 3 days. So that's number one, that's the checklist. Aspirin is okay, it's a controversial thing. Some of us will continue the aspirin till the day of surgery and continue it. Some of us will stop it, but that's not a hard stop for surgery in our mind. And the reason is, aspirin, just a small aspirin per se, is shown to sort of prevent significant cardiac events in the perioperative period, especially in people with vascular surgery, because all of them, as you know, most of them have some sort of coronary disease. So if they're on aspirin, it's likely to have a coronary disease. So don't stop the aspirin. We usually stop the antiplatelets, another checklist that we have to get through. Now, those are the main things for the preoperative things that we check, okay? So once the patient sort of comes into the operating room, everybody gets an NG tube for aortic pathology. It's not a question, it should be an automatic thing, not an OG tube, but an NG tube. And because we usually keep an NG tube in for 24 hours and we take it off, we try and take it off after 24 hours, but some people get, ileus and they end up having the NG tube for 3 days and so on and so forth. Essentially, that's just to prevent aspiration. When they have abdominal surgery, just like any abdominal surgery, if it's pretty painful, in fact, operating on the retroperitoneum is usually more painful than your standard abdominal surgery like bowel resection. That's just the way, because when you go inside, we sort of cut through all those retroperitoneal nerves and sometimes could be very, very painful. So that's an aspiration prevention, NG tubes. Everybody gets a Foley. It's just any abdominal surgery gets a Foley to decompress the bladder. Obviously, when you go operating on the aorta, remember, we are going down into the iliac arteries, so that if the bladder is full, it's going to pop up into the pelvis and obstruct the view of your iliac arteries, and sometimes even the lower part of the aorta. In terms of, those are the basic things. I would still consider that as a pre-procedural checklist of what needs to be done. Everybody gets an A-line for an aortic surgery. In terms of IVs, again, it's one of those controversial things. A lot of people will put central lines in or have a central line in case something goes bad. But if the anesthesiologist is comfortable just putting 2 large bore IVs, that should be okay. But a central line is not a bad thing to do. In my previous life, everybody got a central line because the anesthesiology team felt like it was the safest thing to do. if they needed to sort of monitor some of the CVPs and stuff intraoperatively for fluid management, it would help them. But it's not a hard stop, but it's something we check out for. Like for example, an anesthesiologist may need to put a central line. So we've got to plan for all that prior to surgery in terms of timing, right? So, you know, unfortunately, these aortic surgeries, when you have a 7:45 or a 7:30 start, it may not start till 9 o'clock. But if we're prepared for all these things, then hopefully we can start 15, 20, 30 minutes earlier, as long as all these are done. Because that's the delay, is the anesthesia preparation once they get in the room. I'm not saying in a bad way, it's a good thing. They have to prepare it, but that's the delay that they have. You know, intraoperatively, what do we watch out for? What are the things that we need? What is the team looking for? You know, I think, you know, primarily everybody so all open aortic surgery, and we're talking about open, we're talking about endovascular in a little bit. All open aortic surgery has to have some sort of a self-retaining retractor. In Adina, we have both. The Bookwalter and the Omni retractor. I think that's the only two ones we have. Those are the most commonly used ones. I personally use the Bookwalter on everybody. I think Dr. Carr used the Bookwalter on anybody. So any open abdominal, does he use the Omni? Use the Omni. Okay, Dr. Carr uses the Omni. So just be aware of that. And that's any open abdominal aortic surgery. Like for example, if you were to do a mesenteric bypass, you know, as an emergency, and or any abdominal surgery, if you've got to go back and just make sure the Omni and the Bookwalter are ready. But what I went down, I was talking to Christy yesterday. We have plenty of Omni plenty of Bookwalters. I think so. We have 4 or 5. So it's not. I mean, I would so. For example, if somebody gets the Omni into the Bookwalter into the Omni, it's not a big deal because you have them on separate PEEP packs. So just make sure that's one of the checklists that we have to have for self-retaining retractors. We did go down in terms of preparation. I talked to Christy about how it's never, when you are in the case, it's almost never appropriate just to have one instrument of each. So for example, if you see there is an instrument, there's only one of them, and automatically a light has to go up, like ting, ting, ting. It's always good to have 2. And the reason why it is good to have 2 is that in our body, whether it's a clamp or anything, we always mirror ourselves, right? We have 2 iliac arteries, we have 2 renal arteries, and so it's always good to have 2 of each and every instrument. Even if it's if you see there's a long, you know, needle holder, that should automatically be a thing. Well, why is there only 1? There should be at least 2. And the reason is, what if you drop a needle holder? That's one main thing. And the second thing is always, it's in terms of being handy. Once you load a needle holder and give it to the surgeon, the scrub tech has the ability to load a second needle ready to go. And as we do these cases, you'll find out that it is very important, because there are instances when, especially if you get into bleeding, when somebody's putting a pressure on the thing and we pass off a needle holder, it takes time and it just kind of disrupts the thing. So it flows more smoothly for an open aortic surgery. You know, in terms of what else to watch out for, you know, blood pressure management is one of the important things. We try and keep it normotensive during open aortic surgery. In fact, we like the patient slightly below normotensive. So for example, if the patient is living at a blood pressure of say 120 to 140, when we do the open aortic surgery, at least during the pre-clamping part, we like it slightly below, like 100, 110. So don't panic. Even if it goes down to 90, it's okay. We call that, there's a term called permissive hypotension. And it's very important because when you clamp the aorta, just imagine you've got a big pumping vessel and you've got a pressure head of say 140, 150, 160 millimeters of pressure. It is more difficult to clamp that rather than to clamp a blood vessel that's got a pressure head of 80, 90, or 100. That's a simple reason. So there's less damage. So for example, the blood vessels have a lot of calcium in them, and most of them have calcium. You're never going to find a blood vessel that's just pristine, it's clear. That's not why they're in the operating room. They have diseased blood vessels, right? So when you clamp a blood vessel, what happens is you crush calcium along with it. With a higher pressure head, sometimes what happens is that calcium, because you got to use more pressure to clamp it, will penetrate the aorta or the blood vessel and cause bleeding. And that is probably the number one cause for mortalities in open aortic surgery, is during the clamping and declamping of aortas. Most people would think that, oh, it's during when you're dissecting the aorta, you somehow sort of mistake something and nick something. Typically, those could be easily repaired. People don't die from that. Of course, you get a lot of bleeding, but those could be easily repaired, right? So clamping and declamping is one of the things that we get, and we got to be extra careful and get nervous about is, number one, when we clamp, try and find a soft spot. If there is no soft spot, if we know that we've clamped on calcium, my God, we better make sure that we release that clamp slowly and we're thoroughly inspecting it when we leave the operating room, because calcium, there will be spicules that penetrate. That's something about permissive hypertension. But dwelling a little bit, just in preparation, when we do, say, a ruptured aneurysm or anything is bleeding and ruptured, I always tell, and you'll see that we haven't done any so far, but you will see me or Dr. Carr say that, hey, tell the anesthesiologist, hey, Dr. John, who's giving the name, can you make sure that you drop the blood pressure down to 70 or 80, okay? And it sounds counterintuitive, but counterintuitive for compatibility with life, but that is compatible. So what we do is we decrease the blood pressure to the point where it's compatible with life, which is a lot below what people live at, to decrease the amount of bleeding. And that's just, there's no rocket science behind it. The less pressure, less flow, less blood loss. So if somebody comes in, say I get called for a patient, again, let's cross our fingers, somebody's trocar gets stuffed into the vena cava and or the aorta, okay? It's gonna happen at some point or the other. And say, oh yeah, we need Dr. Rao to come into the operating room. The first thing I say, I'll tell the anesthesiologist is that do not at any point try to increase the blood pressure to a normotensive state. Because all you're gonna do is you're gonna pump more blood out of the body, right? You wanna keep as much of that intravascular. So that's called permissive hypertension. We all got to be aware of that because the circulating nurses, anesthesiologists, everybody could get a little nervous seeing a blood pressure of only 50 or 60 or 70 up there on the field. That's okay. And what will happen is you'll see that if and when we get control of the blood, the blood vessel and or we repair it, then we say, okay, bang, start infusing fluid, start giving the blood, do all that stuff. So we hold all the blood products and all the IV fluids till we get control of the bleeding. And after we get control of the bleeding, they can start transfusion and doing all their protocols, if that makes any sense. A couple of other things to watch out for in terms of an intraoperative state. In terms of grafts, there's two kinds of grafts. There's basically a Dacron grafts, which are called HemoShield, and they're made out of Dacron. It's not rocket science, basically. Dacron is, like a polyester material. And then we have PTFE. If you look at the timeline of vascular grafts, we started from actually making grafts out of silk, literally out of silk, parachute silk. That was the first artificial material that was discovered to repair aortas. So the parachute silk, they sort of wove it in a way that was thicker than your typical parachute silk, like probably a double layer of parachute silk. And then we would sort of sit it in a blood bath for about 15-20 minutes, wait for all the pores to get clogged up with the patient's own blood, and then start sewing. As you know, it's not an ideal, it bleeds a lot, it tears a lot, so on and so forth. So silk has been taken away. And then Dacron was introduced, oh my God, we're talking about 30, 40 years, no, 50 years ago, Dacron was introduced as the next alternative to aortic grafts. Now Dacron first was, they have something called open pore and closed pore. Any of you guys here who've been there for a long time, all you guys are relatively young, actually it's a very young team, but If any of the old people, any old guys who have been here for a long time, if you remember, we take the Dacron, the open pore one, stick it again in a pool of blood. Actually, we had to wait for about 20 minutes in preparation for the graft, so all the pores would seal. With the patient's own blood, and then take it up and then sort of flush it and then sew it on. We don't do that because right now what they've done to Dacron is they've knitted it in a tighter fashion, and they've also impregnated it with gel so it doesn't bleed as much. Okay, so that's Dacron. And then came PTFE, which is basically polytetrafluoroethylene or Teflon, Gore-Tex, what Gore makes, which is essentially a PTFE material. And that was the most recent one. Again, still it's about 35 years old, but that was the most recent one. And unfortunately, we haven't had any graft since then, right? And the third kind of grafts are the biological grafts, and we'll talk about that briefly. Biological grafts are typically grafts that are human cadaveric grafts that we use. They'll either be the human cadaveric aorta or even human cadaveric iliac arteries, human cadaveric femoral arteries that we use. The only time that we use those, is in infected fields, right? We can't put Dacron or PTFE in an infected field, so we'll use those. Then we got to be aware that if it's an infected aorta and we're doing that, or if you're going through an infected field, hey, is there the cadaveric graft available? Is there a bovine graft available? And the next thing you got to ask is, how do we prepare that graft? Or is there any preparation step pre-deployment, as in what is the storage for it? And the second part is, does it need to be thawed out? How do you prepare it? And the third part is, when you hand it off to the surgeon, is there any flushing or any sort of cleansing part that goes with it? Okay, so those are the three things that we got to watch out for in case of any biological graft. Is that a bovine? If it is a bovine graft, a cadaveric graft, whatever it is, any biological stuff, think about preparation. And the way to talk about that is just ask the rep. Those are the best. And in fact, the reps are probably better or worse than even me in biology, because we don't put that every day, day in and day out. It's one of the things we use rarely. There's different kinds. And then the reps are the one that sell it, on a day-to-day basis, so they know how to prepare it. So get yourself, you don't have to be familiarized with it, but just be aware that if that graft is going to be implanted, to ask the rep, hey, what is the preparation for it? Okay. You don't have to ask Dr. Me or Dr. Carr, directly go to the rep, if that makes any sense. Okay. Briefly, we'll talk about what are the advantages and disadvantages of Gore-Tex versus PTFE. Both can be used safely. Cases can be done on both equally well, okay? Some surgeons will use Dacron, some surgeons will use PTFE. I use both. Just be aware that it's not a bad thing. For example, if PTFE, the other day PTFE graft was not available due to some confusion, we used Dacron graft, wasn't a big deal, patient's going to do fine. There is some data to suggest, and it's important, the reason why I like PTFE graft, there is some data out there in the vascular surgeon literature, for that matter, even the cardiac surgeon literature, that PTFE has a slightly decreased chance of infection and aortoenteric fistulas. Does anybody know what an aortoenteric fistula is? So basically what happens is, and the reason is Dacron is rougher, so sometimes what will happen is the duodenum or the small intestine sits on top and it keeps rubbing. And the reason for rubbing is, as you can imagine the life cycle of the human body, your aorta goes poop, 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 like, 75 times a minute, times an hour, or times your lifetime, you can imagine. So that banging of that little like tap, 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 tap against the small intestine, because it's a rougher surface, sometimes will gradually denude the duodenum and the small blood vessel. And this is a long-term risk, not short-term. So we're talking about like 3, 4, 5, 6, 7, 10 years from now, 20 years from now even, you can get aortoenteric fistulas. So I tend to use PTFE grafts whenever possible, not thinking about the short term, because you could sew it into it easily, but me thinking about a patient that I'm going to see 10, 15, 20 years later.
You've got about 5 minutes.
Yeah, okay.
Okay.
That's basically it. And then the other thing you got to worry about is basically, the end of the case. All patients need to go to the ICU, no questions asked. That should just be a protocol. Anytime a patient has an open aortic surgery, open abdominal wall surgery for blood vessels, any blood vessels that are fixed in the abdomen need to go to the ICU. And it's not a question of, oh, can he go to Northeastern? No. Everybody goes to, because it's a very rocky thing because of intra-abdominal change in blood pressures during the first 24 hours. I am going to leave. I'm sorry for the delay. I really apologize, but I wanted to talk briefly about open versus endovascular and what are the differences and preparations for it. I'm going to leave some graphs in here during the daytime. I'll bring them from the office. I don't want to go to the office and come back. So I want you guys to, each of you to sort of, sometime during the day, touch your hands on what an endograft looks like and feels like, so you understand what it is. For endograft, for endovascular cases, it's a hybrid procedure. So as you guys know, we have both open and the cath lab staff in. Just be aware the preparation is a lot less. We don't have to be as paranoid. There are centers, including me, that have pretty much done all endovascular cases under local anesthesia with MAC. And if you've done these cases, you'd understand why you could do them. So the only incision we make is the groin, and even those we don't make incisions anymore. We deploy the what we call ProGlide or pre-tie sutures, and the incision is about yay big, so we can actually numb them, do them under MAC. And just be aware that down the line, one of the advantages of doing it is, say for example, you have a ruptured aneurysm. The good news is this: 80% of ruptured aneurysms can be done with an endograft. 80%. Only 20% of them require open surgery. So in preparation, when we have a team around to if you start doing ruptured aneurysms, we've got to really have a hybrid room staff to do them. They're very quick. There's no opening. There's no massive, crazy blood loss and blood products that are needed. So you just got to move quickly. And the way we manage that, essentially, just in a very, very brief term, is we have to have occlusion balloons. So the first thing we do is we get arterial access and we shove a big compliant balloon, and it's called a compliant balloon because the balloon can be blown from as little as 15 millimeters to as high as 44 millimeters, depending on the amount of saline you inject into it. First thing we do is put a ley line, get a balloon up, blow it up, get control of proximal pressure. So you understand immediately of how and why the mortality rate is so much more different if you do it endovascularly. Because those who have done open ruptured aortas, you know that when we get into that belly and before we clamp, there is a lot of blood loss. Because what we do is we disrupt that outer layer. So there's a thin layer that's sort of containing the massive rupture. Because if it's a massive rupture, they die. There's sort of this retroperitoneal space. So as soon as we get into that retroperitoneal space, you get this whoop, like a bloodletting. Almost half the patient's blood volume is lost just from entering that retroperitoneal space. So when we put that occlusion balloon and put it up, we don't have that. And that basically is the key of why these patients, the survival rate for doing them on the endovascular is so much better. It's almost like a 20-30% improvement in mortality rates. We used to say mortality rates are 95% for ruptured aneurysms. If they get to the hospital, there's a 50% chance you may live or die. But right now we've gotten to a point where there's almost an 80% chance you'll live and only a 20% chance you'll die for ruptured aneurysm because of all these technologies, right? And the key thing in the last 15 years that has driven that, 20 years that have driven that, is the endovascular revolution. So, for example, if you talk to a guy like me who's been out of practice for about 20 years, my first 5 years, everybody who's done open. The last 15 years, I would say almost 80% of my ruptured aneurysm volume is all endovascular. And if you look at that timeline, in terms of mortality rate, what we've been able to achieve is pretty significant.